Our maternity content is split into 3 exams. The first exam includes chapters 1 through 7, which cover a broad overview of maternal child nursing concepts and information about assessing and caring for the pregnant person and family during the antenatal period. Chapter 1 explores the current trends in maternal child health nursing. The focus is on the family and creating a home-like environment for the birth. This is now an inclusive experience rather than the focus being on the mother and having the father wait in the waiting room. We have dramatically increased the technology that we use in the birthing process, and we've increased surgical and assisted births based on earlier recognition of fetal distress. Combined, this has increased survivability of very premature infants and decreased infant and maternal mortality, which is part of the Healthy People 2020 goals. Some issues or goals that you will find in Chapter 1 that will be very helpful for your teaching plans are information about teen births, smoking during pregnancy, substance abuse and alcohol use during pregnancy, obesity, health disparities, and problems with access to care. Chapter 2 focuses on ethics and the dilemmas that are specific to the maternal child health nurse. On page 15 in your textbook, they discuss some of the dilemmas in box 2-1. Legal risks are also discussed in this chapter, which focus on fetal monitoring and the importance of using evidence-based practice. Chapter 3 covers genetics, conception, fetal development, and reproductive technology. Genes are either recessive or dominant. A recessive gene needs 2 genes or 2 alleles to display the traits. In this Punnett square, you can see that if one parent has a trait that it expresses, it would have 2 recessive genes. If the other parent was a carrier, it would have a dominant and a recessive gene. And in this example, you would have 50% of your children would be carriers where they wouldn't display the disease or the defect, and 50% would have the actual disease. Genetic disorders are usually related to defective recessive genes. When performing your health history on the antenatal client, you want to ask for risk factors of genetic disorders, and that would include family history, patient history, a child that patient has had who has a disorder, and then the patient age, because as we age, the risk increases. If you do recognize that the people that are there seeking the antenatal testing or prenatal care are concerned or at risk for a genetic problem, you should refer them to a genetic counselor. Our role really is to educate and provide support, but never advice. It's the role of the genetic counselor to provide them with more definitive information and to help them make decisions. Teratogens are drugs, virins, or infections that the mother is exposed to while pregnant. These are specifically named because they can cross the placental barrier and cause harm to the developing embryo or fetus. The fetus is the most vulnerable during the first 8 weeks, and that's when the organs are being formed, so that's called organogenesis. Oftentimes, the mother may not even be aware of the pregnancy while taking those substances that could be harmful. As soon as you have contact with a patient who has a suspected or confirmed pregnancy, it's important that we teach them to avoid hot tubs, drugs, medications, or chemicals that could be dangerous to the fetus, deli meats and raw meats, and cat litter boxes, and even sandboxes without covers because of the risk of cat or animal feces. Torch infections are specifically dangerous, and we'll see these again in another chapter, but it's toxoplasmosis, other, such as Hep B, rubella, cytomegalovirus, and herpes. Embryonic and fetal development is also discussed in Chapter 3. Fetal circulation creates a right to left shunt because the ductus venosus, foramen ovale, and the ductus arteriosus bypass the liver and the lungs so that the developing fetus does not have to attempt to filter any of the maternal exposures, and the lungs don't get then full of blood and fluid when they don't have any counter pressure from the act of respiration, since they're not breathing. The placenta connects the mother to the fetus and provides everything then that the fetus needs. There's a chorion, the fetal side, and a decidua, which is the maternal side. So when we talk about obtaining samples from the placenta, we talk about obtaining chorion samples because that's the fetal side. A normal, well-developed umbilical cord has 2 arteries and 1 vein, and we affectionately refer to umbilical cords as AVA. And then the amnion and the fluid is an important concept as well. The amnion itself is a double membrane sac, and it consists of the amnion and the chorion. The amniotic fluid is produced by the amniotic membrane during the first trimester. Then, after the first trimester, the fetal kidneys start to work and develop or produce urine as a byproduct of eating and drinking the amniotic fluid, and the amniotic fluid is then replaced by urine. The maximum amount of fluid that we typically see is about 1 liter, and you see that at about 34 weeks. And because the fetus is continuing to drink and eat the amniotic fluid and incorporate that into itself and create meconium, at term birth, there's only usually about 500 to 600 milliliters of fluid. Amniotic fluid is very important because it acts as a cushion and provides a constant temperature for the fetus, as well as allowing for free fetal movement. An intact sac, the intact amnion, is incredibly important because it acts almost as like a skin layer or a bubble, preventing or protecting the fetus from infection. 2 problems that can occur with amniotic fluid are polyhydramnios and oligohydramnios. Polyhydramnios occurs when there's too much fluid, and this oftentimes occurs when the fetus cannot eat or drink the fluid, such as a GI tract abnormality. We also see this with certain chromosomal deformities, cardiac deformities, and then fetal hydrops and neural tube defects. On ultrasound during the biophysical profiles, they'll notice that there's more than expected fluid, and they'll start tracking that, as well as doing higher level ultrasounds to determine if there's a structural or congenital defect with the child. Oligohydramnios is when there's under 500 milliliters of fluid, and that means that the baby is eating and drinking but not making urine. And this oftentimes is related to fetal congenital kidney disorders or a decreased placental blood flow, and both of those relate to a decreased fetal renal blood flow, which causes decreased urine production. So we take the measurement of amniotic fluid very seriously during our ultrasounds. Infertility is an issue that many people face in our society. Both the partners are examined to see how they may or may not play a role in the issue. Women are examined for problems with ovulation, the endometrial lining, tubal and pelvic pathologies, and cervical problems. Because the woman is the host for the pregnancy, there's a lot more obviously that can go wrong. Men submit semen for analysis to make sure that they have adequate numbers of sperm and that the tail, the flagellate, is working appropriately and that the semen can actually, or the sperm can actually swim within the semen. One of the big consequences of infertility is emotional, and infertility has a real negative emotional impact on a couple, or it can, I should say. Sexual activity can become prescribed, and many people develop a dysfunction because they feel like they have to have sex at a certain time to increase their chances of pregnancy rather than allowing it to be spontaneous and based on, mood or feeling. And then you might see even withdrawal from social events for many reasons. That it might be painful to see other people who have children, or they don't want to be asked questions about, when are you having children, or, how is your infertility treatment going if they just had a failure. So one of the roles of the nurse, again, is to provide education and support, but to really look to see how are they coping with the kind of challenges of infertility. Chapter 4 covers the physiological aspects of antepartum care. And preconceptive health care includes medical, behavioral, and social assessments that help you identify if there's any risks to health or pregnancy. So any risks to the pregnant person or to the developing fetus or potential fetus if they're not pregnant yet. This includes performing a physical exam, obtaining lab work, performing a pap smear, cultures to check for gonorrhea, chlamydia, things like that that could cause problems during the pregnancy. And our role really is to help families become more knowledgeable and prepared for pregnancy and birth. So really we want to give them the tools to feel confident and to be successful. Provide them with information that can be used to enhance their health before they become pregnant. And this includes things like nutrition, the right vitamins to take, like folic acid to prevent those neural tube defects, and iron to really help beef up your blood counts, the importance of exercise and self-care, and contraception cessation. So ideally we want to see 2 to 3 months of normal periods prior to pregnancy attempts, and then 2 to 3 months of good nutrition, folic acid, no alcohol, and this is for mom and dad. So both the mother and the father really should take steps to reduce risks by modifying both of their behaviors. And this includes some screening, some immunizations, and making sure that they both understand that genetically they both play a part in the development and the outcome and success of this pregnancy. And so they, both should be invested in creating a healthy child. So after preconceptive healthcare comes, the question, am I pregnant? And there's, 3 kind of stages or grades of a diagnosis of pregnancy. There are presumptive signs. So these are things that the pregnant person is going to experience where they say, I think I might be pregnant. Lack of menstruation, so amenorrhea, nausea or vomiting, some changes in their breast tissue, increased fatigue and increased urination, and then sometime around 20 weeks, quickening where they start to feel the baby move. So those would all be signs that would say to us, what we need to do some further testing to see if you're pregnant. Probable signs are anatomical changes seen by the provider. So this would include Chadwick's, Goodell's, Hagar's sign, cloasma, linea nigra, ballottement, and positive urinary pregnancy test or a positive blood pregnancy test. So those are all just probable signs because there are certain things that could give you false pregnancy tests. Then positive signs or absolute proof include being able to hear fetal heart tones, being able to palpate fetal movement when the examiner can palpate it, or doing an ultrasound and seeing fetal cardiac movement, so actually seeing the little heart beating in there. Those things are where we know without a doubt that the person actually is pregnant. After we confirm a pregnancy, people always want to know, when am I due? So there's a couple ways that we can do this. The most accurate way oftentimes is with ultrasound, as they can determine the average, kind of length, so kind of height and weight of the developing fetus, and plug it into a chart that says this is, how far along you probably are, and this is when you're probably going to be due. But there's Nagel's rule, which says if you know the first day of your last menstrual period, you take that date, subtract 3 months, add 1 week or 7 days, and that gives you your estimated due date, or estimated date of delivery, estimated date of confinement, which would be called an EDC. And that's the date that the baby or the mom would be confined to the maternity ward. So you might see different abbreviations. All of that's fine. At about 20 weeks, you can measure from the pubic symphysis to the fundus, and the length in centimeters is the week and gestational age. It should match. So if it's greater, consider that you have a large baby or multiples, and if it's less, consider that you have a small baby or some sort of demise. So really this comes into play if the person's been measuring normally over and over and over again, and then suddenly at their next checkup, they have not grown at all, or they're smaller, then we start to worry about demise. And then you should be familiar with the gravity term, preterm, aborted, living, and multiples kind of abbreviation that we use to document the number of pregnancies that a person has had. And you can review those on page 54 in your textbook, but you should be able to identify what each of those letters stands for. There are a lot of physiologic changes during pregnancy. The vital signs increase slightly to compensate for the increased circulatory needs. The blood pressure goes up about 10 to 15 millimeters of mercury, both systolic and diastolic. The heart rate increases, so a normal resting heart rate is about 10 to 20 beats per minute over normal. A resting respiratory rate is also slightly increased at about 16 to 24, and the temperature remains roughly the same at 97 to 100, so maybe a slight elevation. It's super important to obtain baseline vital signs and monitor trends. Some changes that I want to point out physiologically. For the reproductive system, there's breast enlargement, areola darkening, lactation, cessation of menses, uterine stretching, and the formation of a mucus plug. Cardiovascular system increases in volume, heart rate, cardiac output, stroke volume, basal metabolic rate, white blood cell count, and plasma, which causes a dilutional anemia. There's an increase in coagulation and venous stasis, which puts you at risk for DVTs. And as the baby grows, you're at risk for supine hypotension. Many pregnant women will develop an S3 cardiac sound and varicose veins. The respiratory system sees an increase in volume and respiratory rate, as well as an increase in pH from respiratory alkalosis from slight hyperventilation. Mucous membrane congestion is normal, epistaxis is not uncommon, and the diaphragm elevates later in pregnancy, which can lead to shortness of breath. The renal system shows an increase in glomerular filtration rates, and it's not uncommon to spill protein and glucose in the urine, as there's kind of a decreased tolerance for glucose. Urinary stasis, so the inability to fully empty the bladder, as well as urinary tract infections, and pyelonephritis, which is kidney infections, are not uncommon. And kidney stones can occur during pregnancy in someone who's never had them before. GI, you see an increase in appetite, cravings, and avoidance, a decrease in peristalsis, and an increase in reflux. Constipation, hemorrhoids, gallstones, and gum disease are all common during pregnancy. In the musculoskeletal system, we see a change in center of gravity. The gait changes, and we see a waddle with lordosis, and all of this leads to increased number of falls. With the skin, we see hyperpigmentation, striae or stretch marks, and varicosities, which are varicose veins. The endocrine system, we see a change in hormones to support the pregnancy, and we need to monitor for gestational diabetes and hypothyroidism. With the immune system, we see the body adjusting to a foreign traveler, and if the mother is Rh negative, we may have to give RhoGAM. Chapter 5 talks about the psychosocial and cultural aspects of the antepartum period. First, we look at the maternal adaptation to pregnancy. It's not uncommon for both the pregnant person and the partner to have some feelings of ambivalence early on, until they hear, see, or feel things that make the pregnancy more real. They may not be sure how they actually feel about being pregnant. And teen parents specifically have the increased challenge of tackling two developmental tasks at once, both trying to succeed as an adolescent and as the pregnant person, and then parenthood. The father during pregnancy may experience Couvede's syndrome, where they actually have the same morning sickness or weight gain and food cravings as the mother, or they may even have their own. So their pregnancy-like symptoms and discomfort similar to pregnant partner, nausea, weight gain, and abdominal pains. And many men go through, or partners go through, what we call phases of pregnancy. And the first one is the announcement phase, where they oftentimes have kind of a strong emotional response to the idea of pregnancy. Then we go into a moratorium phase, where there's not a lot of thought about it because they're not experiencing the same feelings as the pregnant partner. And then once the person is showing the pregnant person is showing lots of outward signs of pregnancy, and the partner can feel, the movement and the kicks, and has seen ultrasounds, and really starts to realize this is happening, then they might experience the focusing phase, where they start to think of themselves as being that, father figure, or, that partner, that other parent. And they start planning to participate in the labor and delivery, or start thinking about preparing for parenthood. We want patients to participate in classes and appointments, but we also want their partners to participate as well, to help them feel more involved, and for the couples to kind of experience the pregnancy together. Intimacy during pregnancy or sexuality during pregnancy can be a difficult conversation. I worked in an office where we did OB, and my provider, I think, was really great about kind of opening that conversation and those doors. It's really important that you encourage communication between the partners and talk to them about alternate positions and forms of sexual expression. If there are any, like pelvic rest where you can't, put anything in the vagina, or if there's, bed rest, or for whatever reason it's uncomfortable. Social support is also critical during the antepartum period. So finding out who is available to help provide support to the pregnant person and help that pregnant person understand that they're not going to be pregnant forever, but they do need to take it easy sometimes. So they are going to need to ask for help and have them practice having those conversations. Invite key support people to appointments so they can also hear the importance of what you are saying to that person in terms of what they can and can't do, and what they need to be doing for rest or taking care of themselves. On page 104, there's the critical component strategies for nurses improving culturally responsive care. And we talked about maintaining an open attitude, examining your own biases and trying to avoid stereotyping, learning the language of the people that you're taking care of, and trying to participate in professional development or continuing education to become more culturally responsive. Counseling during pregnancy really focuses on education, and specialized classes have been developed to meet the needs of not only, here's what pregnancy is, but very specific groups as well. So there's breastfeeding, sibling preparation, prenatal, postpartum exercise. There's even online childbirth preparation classes. But the overall goal of childbirth education is to promote the competence of expected parents in meeting the challenges of childbirth and early parenting. So really what you're doing is giving them tools so that they can be successful in parenting, because it can be very hard. Chapter 6 reviews AntiPartl testing. So tests that we can use to screen for adverse outcomes in pregnancy and labor include biophysical, psychosocial, sociodemographic, and environmental. On page 116 in your book, table 6-1 talks about common maternal conditions that would indicate the need for antenatal testing. And I think these are important to recognize. Hypertension, kidney disease, heart or lung disease, autoimmune disease, type 1 diabetes, because again, that really increases the risk of genetic congenital defects. Pregnancy-related hypertension, anytime there's decreased fetal movement, any problems with the amniotic fluid, and then if the baby is too little, too big, if there's too many, not that you can have too many, but if there's more than one, if the pregnancy is going post dates, and if the parent has a history or the mother has a history of unexplained fetal demise previously, or some sort of RH incompatibility. And we know that these risk factors have kind of a cumulative effect, so the more that you can identify, the more important it is to get tested. So if the person only has a history of kind of borderline hypertension and nothing else, then they would be a lower risk than the person who has type 1 diabetes, who's developed pregnancy-induced hypertension and has gone post dates. So Antepartum testing of the fetus includes biophysical, which is the ultrasound, Doppler, and MRI, biochemical, which is CVS, amniocentesis, and fetal blood sampling, and then antepartum testing of the mother includes maternal assays. So these are like the blood tests, the AFP, the triple and quad markers. And then tests of fetal status and well-being include kick counts, non-stress test, the VAS, the CST, AFI, and BPP. So think about for a second kind of what we talked about in terms of how these assessments are done. Our goal is to provide information regarding what the test is going to be, make sure that they're comfortable, provide reassurance and psychological support, and then document their response and the results of the test. Report the test to the provider to make sure that they see the results, and then schedule follow-up. When you're studying these, I would just kind of create a chart maybe of the different ones and the age ranges that they can be tested or used for. So for example, when you're doing your biochemical assessments, the CVS looks for cystic fibrosis and can be done between 10 and 12 weeks versus amniocentesis. Also does genetic testing, but infection screening and lung maturity, and occurs between 14 and 20 weeks. So, in very early pregnancy, we would do CVS versus amniocentesis after 14 weeks. The AFP, or alpha-fetoprotein, is usually occurs in the second trimester between 15 and 20 weeks. And the reason that we wait is because as the fetus develops, proteins from the fetus leak out into the maternal bloodstream, especially with children who have neural tube defects and then ventral and abdominal wall defects. So you'll see an increase in alpha-fetoprotein for them. With children who have Down syndrome, like trisomy 21, they actually don't secrete as many AFPs, and so you'll see a decrease in AFP. The triple and quad markers look at AFP, HCG, estriol, inhibin A, neural tube defects, and trisomy 21. Chapter 7 discusses high-risk antepartum nursing care. Preterm labor is the onset of labor at 20 to 37 weeks, and preterm birth is delivery before 37 weeks. The fetus must be at least 20 weeks old, or the age of viability, otherwise it is considered a spontaneous abortion. Prematurity can be divided into 3 categories: very preterm at 20 to 32 weeks, preterm at 32 to 34 weeks, and late preterm at 34 weeks to 36 weeks and 6 days, which is written as 36 and 6/7 or 36 plus 6. At 37 weeks, it's no longer premature. Many preterm infants also have low birth weights. This can be categorized as low, less than 2,500 grams or 5.5 pounds, very low, less than 1,500 grams or 3.3 pounds, or extremely low, less than 1,000 grams or 2.2 pounds. Most preterm labor and births are spontaneous. However, we do deliver preterm babies intentionally for critical maternal fetal issues like severe hypertension, severe preeclampsia, hemorrhage, and intrauterine growth restriction, which signifies that there's something wrong with the placenta or the uterus. Prematurity is the #1 cause of neonatal mortality, so infants up to 28 days, and the number 2 cause of infant mortality, so infants that are 1 to 12 months old. The annual cost is roughly $26 billion for care and issues associated with prematurity, and long-term problems for premature babies include cerebral palsy, hearing and vision problems, and chronic lung disease. It is a Healthy People 2020 goal to decrease preterm births from 12.2% to 11.4%. There are no truly predictive factors for preterm labor. The primary risk is a history of preterm labor. Some other contributing factors are premature rupture of membranes, hypertension, diabetes mellitus, smoking, and drug use. The onset of preterm labor is usually spontaneous preterm labor or preterm premature rupture of membranes, with regular contractions greater than 6 per hour and rupture of membranes or cervical effacement greater than 80% or dilation greater than 1 centimeter. So in order to call it preterm labor, there's either regular contractions or rupture of membranes with cervical changes. Interventions to prevent preterm labor have not proven to be effective. The aim really is just to delay delivery for roughly 72 hours to give the steroids time to work and mature the fetal lungs. This also gives us time to transfer the mother to a higher level of care if needed, and to treat GBS if present in the vagina. We do not stop preterm labor if there is active hemorrhage, severe maternal disease, fetal compromise or death, or signs of infection. And preterm labor should not be stopped for spontaneous abortion, which would be preterm premature rupture of membranes prior to 20 weeks. Treatment for preterm labor, when we do treat it, includes magnesium, which is a loading dose of 4 to 6 grams over 20 minutes, and then a maintenance dose of 2 grams per hour IV. It's critical that you as the nurse recognize the signs and symptoms of magnesium toxicity that are listed on page 155 in your textbook. We would notice a loss of deep tendon reflexes, but we would need to respond urgently or emergently to respiratory depression. Betamethasone is also given in 2 doses, 24 hours apart, and this is the steroid that helps improve fetal lung maturity. We can also try calcium channel blockers such as nifedipine or beta agonists such as terbutaline, and even some prostaglandin inhibitors such as indomethacin can help in the short term delay preterm birth for up to 48 to 72 hours. Preterm premature rupture of membranes, or PPROM, is the spontaneous rupture of membranes at less than 37 weeks. Premature rupture of membranes occurs when fetal development is greater than 37 weeks, but both occur prior to the onset of labor. The goal after the amniotic sac has broken is to deliver within 1 week to prevent sepsis and infection. Some women will experience an insufficient or incompetent cervix. The incompetent cervix has a mechanical defect. Cervical insufficiency refers to the premature ripening of the cervix, so allowing it to efface and dilate prior to full term. Both of these can lead to preterm labor and delivery. Risk factors for cervical problems include having the cervix dilated for procedures such as DNC or cauterization, direct surgical procedures of the cervix such as a LEEP, or parents who were treated with DES. There's a treatment called cerclage that sews the cervix shut to prevent early dilation and loss of pregnancy. Multiple gestations are any time where there's more than one fetus in the uterus. Multiple gestations do increase the risk to both the fetus and the mother, including preterm labor, hypertension, gestational diabetes, antepartum hemorrhage, placental abruption, and placental previa. Hyperemesis gravidarum is vomiting that occurs during pregnancy to the extent that the patient experiences dehydration and electrolyte and acid-base imbalances. This leads to starvation, ketosis, and weight loss, and signs and symptoms of dehydration. Those include dry mucous membranes, poor skin turgor, malaise, and low blood pressure. The goal in the treatment of the hyperemesis patient is rehydration and cessation of nausea and vomiting. Different medications can be used, but remember that currently we are not providing Zofran or ondansetron to pregnant mothers, especially in the first trimester. Diabetes during pregnancy can cause a whole host of complications. Let us explore pregestational and then gestational diabetes. Pregestational diabetes is diabetes that occurred prior to pregnancy, and this could be type 1 or type 2. Pregestational diabetes, especially type 1 diabetes, increase the risk of congenital defects and delayed fetal lung maturity. The risk of macrosomia, or a large gestational age baby weighing 9.9 pounds or greater, is also increased. And because the fetus is used to receiving excess glucose and has a healthy pancreas itself, the fetus is at risk then, once a neonate, of having postpartum hypoglycemia. During pregnancy, the mother is at greater risk for developing diabetic ketoacidosis. It's critical that we teach the signs and symptoms of DKA and what to report and how to manage it. Gestational diabetes is diabetes that occurs during pregnancy. And because it's often not kind of found or doesn't even start until halfway through the pregnancy, the congenital defects are less likely. Fetal macrosomia and postpartum hypoglycemia are still risk factors because the baby is still receiving excess glucose during pregnancy. The mother who develops gestational diabetes should be educated on diet, exercise, glucose monitoring, and proper medication administration, whether that's insulin or oral medication, as well as the signs and symptoms of hypoglycemia during pregnancy. So let's talk about hypertension in pregnancy. Hypertension in pregnancy is any time that the blood pressure is 140/90 or greater. There are different things though. Preeclampsia is not just hypertension. It's hypertension plus multi-system disorders. And basically there's reduced organ perfusion and vasospasm and endothelial activation that causes there to be kind of a multi-system organ dysfunction throughout the body, which leads to spilling of protein into the urine. The only cure for preeclampsia or eclampsia, if it gets worse, is delivery of the neonate and the placenta. In preeclampsia, there's an increase in microvascular fat deposition within the liver, and the person will develop right upper quadrant pain. In about 70% of patients, there's also some changes to the glomerular endothelial lining and fibrin deposition, which causes ischemia and reduction of renal plasma flow and GFR. So this causes basically leaky kidneys, and then a decrease in uric acid, creatinine, and calcium clearance, and a decrease overall in urine output, so oliguria. The coagulation system is activated in preeclampsia, and thrombocytopenia occurs. So this is increased platelet aggregation, so lots of clumping on the injured blood vessels, and activation of the clotting cascade. And this can lead further down the road to DIC. Endothelial damage to the brain results in fibrin deposits, edema, and cerebral hemorrhage, which can lead to hyperreflexia and severe headaches, and then eventually seizures. So that's the mechanism for which seizures occur. And then retinal arterial spasms cause blurring or double vision, photophobia, and scotoma. And scotomia, remember, is the spot in the visual field, like an area of lost or blurred vision. Pulmonary edema is most commonly caused by volume overload related to the left ventricular failure, from the kind of increased peripheral vascular resistance throughout the body. So there's not really a body system that isn't touched by preeclampsia. The diagnosis of preeclampsia usually occurs after the 20th week of pregnancy, and again, hypertension and protein in the urine. Risk factors include developing stroke, DIC, pulmonary edema, CHF, hepatic failure, renal failure, and placental abruption. The fetus may experience premature delivery, intrauterine growth restriction from poor perfusion due to all that vascular constriction, a low birth weight, and they may not be able to tolerate the labor because of poor placental flow or poor uterine flow on the mother's side, which will lead to the need for an emergent C-section. And then stillbirth is a risk as well with preeclampsia. So even though it seems to be kind of a more common problem that we see, it's not without pretty significant risks. So we treat preeclampsia with magnesium prior to delivery to stop eclampsia from developing, as well as antihypertensives like beta blockers and calcium channel blockers. And then delivery of the fetus and the placenta is the only way to actually, quote unquote, cure preeclampsia or eclampsia. But remember that the hormones are still circulating within the body. All of those toxins are still there, and it doesn't go away immediately. It may take days up to a week for things to return to baseline. Since we're tracking things like blood pressure, protein, and signs and symptoms, it's critical for you to get a baseline, watch for trends, and report any changes. Your accurate assessment is going to be essential in recognizing that this patient is getting worse. And any changes neurologically, including headache, visual changes, or deep tendon reflexes or clonus, should be reported immediately. Pain in the right upper quadrant indicates liver involvement, and that makes us concerned for HELLP syndrome. IV mag sulfate is given, again, to prevent eclampsia or to treat eclampsia. The loading dose is 4 to 6 grams, diluted in 100 milliliters, and administered over 15 to 20 minutes, followed by a continuous infusion of 2 grams per hour. And it's really important that we monitor serum magnesium levels to make sure they're within therapeutic range of 4 to 7 milliequivalents per liter. The intravenous infusion continues for at least 24 hours post-delivery to help prevent post-delivery eclamptic seizures. If you recognize any of the signs and symptoms of magnesium toxicity, such as decreased reflexes or loss of deep tendon reflexes, respiratory depression less than 14 breaths per minute, urine output less than 30 milliliters per hour, shortness of breath, chest pain, EKG changes, then you should treat the patient with calcium gluconate 1 gram IV. Of course, you're going to turn off the magnesium as well. Eclampsia is when you actually have a seizure in the presence of preeclampsia, and it's possible for patients to have a seizure disorder and also develop hypertension in pregnancy. One of the take-home points is it's very fast to give a benzodiazepine to try to break a seizure if they have an underlying seizure disorder. And it takes 15 to 20 minutes to provide the loading dose of magnesium if you're trying to break a seizure that's occurring from eclampsia. So if the person has a pre-existing seizure disorder, give the benzo first and then follow it with the magnesium if the benzo doesn't work. Eclampsia is thought to be triggered by things like cerebral vasospasm, hemorrhage, ischemia, or edema. And so it's all changes in the perfusion to the brain. Warning signs would be severe persistent headaches, epigastric pain with nausea and vomiting, hyperreflexia with clonus, and restlessness. If the patient experiences a seizure, remember to stay with them and call for help and keep them safe. So lower the head of the bed and try to turn the head to one side. If possible, log roll the patient onto the left to improve perfusion to the fetus. Anticipate the need for suctioning immediately after the seizure stops to decrease the risk of aspiration, because aspiration is the leading cause of maternal mortality. And then prevent maternal injury by removing any dangerous objects and keeping the side rails up and padded if possible. As soon as the seizure has stopped, suction, position, oxygenate, ventilate, and try to record the time and the length and the type of seizure activity. Administer magnesium if it hasn't already been administered, and allow the patient to rest in a quiet, dark environment as much as possible. HELLP syndrome is hemolysis, elevated liver enzymes, and low platelets, which often occurs as a complication of severe preeclampsia. Hemolysis is when red blood cells are destroyed as they're traveling through constricted blood vessels. The elevation of liver enzymes results from decreased flow of blood and damage to the liver, and low platelets result from platelets clumping at the site of the damaged blood vessels and causing kind of the body to use up all of the available platelets, which leads to thrombocytopenia. Lab values on a patient with HELLP syndrome, and again we're monitoring for trends, would be a decreasing platelet that falls underneath 100,000, increasing liver enzymes, AST and ALT that go above 70 and 50, bilirubin that elevates above 1.2, and an elevated LDH. But the H&H is also going to be dropping, so look at the hemoglobin and hematocrit, which will be dropping secondary to bleeding and destruction of red blood cells. This can cause an abruption of the placenta, which can lead to hemorrhage, renal failure in the mother, liver hematoma and possible rupture in the mother and death of the mother, as well as preterm birth and death of the fetus. It also leads to DIC. Notify the physician immediately if you suspect HELLP syndrome and prepare to keep the patient safe. Just like with eclampsia and preeclampsia, the treatment for this is delivery. At term, the placenta can pump through roughly 15% or 1 liter of the total cardiac output per minute, which means that a significant hemorrhage at the level of the placenta, so if there was trauma to the placenta, if it ripped away from the lining of the uterus, or trauma to the cord, could potentially cause death to the mother and the fetus in less than 10 minutes. Placenta previa occurs when the placenta attaches to the lower segment of the uterus. And there's total placenta previa and partial placenta previa that actually cover the os, and then marginal placenta previa that kind of butts up against the opening of the os internally in the uterus. And then there's low-lying placenta that is just in the lower segment of the uterus, but doesn't actually come up against the cervical os. And why this is important is that during ultrasound, they look to see where the placement is of the placenta, because during delivery, remember that the cervix dilates and effaces. So if the placenta is attached to the cervix and the cervix starts to dilate, the placenta is going to tear and there's going to be bleeding. So we see hemorrhage with placenta previa usually in the 3rd trimester as we start to see cervical changes. Placenta previa bleeding is painless and bright red and usually fairly heavy. And for this reason, it's super important that there's no internal exams or internal fetal monitoring for the patient with vaginal bleeding until previa is ruled out, because sticking or inserting a speculum or anything else in there at that point in time could enhance the hemorrhage or cause death or demise. The treatment for placenta previa is cesarean delivery and blood transfusion to replace lost blood. With just a low-lying placenta, they can attempt a vaginal delivery, but have to have people on standby for an emergency C-section if hemorrhage starts to occur. So for you, it's going to be really important to observe for vaginal bleeding, any signs and symptoms of hemorrhagic shock, and then monitoring lab values like a CBC, platelets, and clotting studies to make sure that the person isn't getting worse. Placental abruption occurs, or abruptio placentae, when there's a separation of a normally planted placenta and the wall of the uterus. This causes a hematoma to form that kind of starts to destroy the placenta. It basically puts pressure on the placenta if it's trapped, and bleeds into the decidua, which causes then greater hemorrhage and placental separation. On page 159 in your book, there's pictures of a mild versus a moderate versus a severe placental abruption. Depending on where the abruption occurs, if it occurs at the edge of the placenta versus inside, you may or may not see frank external bleeding. Things like eclampsia, the use of stimulants such as cocaine or methamphetamines, direct trauma, hypertension, preterm premature rupture of membranes, and HELLP syndrome can all result in abruption of the placenta. And the signs and symptoms, rather than bleeding, and if they do bleed, it's usually kind of a darker, slower bleed, but rather than bleeding, what you're looking for is a severe, sudden, intense abdominal pain and uterine irritability and contractions. So you want to palpate the uterus for contractions, tenderness, hypertonus, which would be kind of a hyper contracted state, and increased uterine distension. And again, these are going to go for ultrasound to see the extent of the issue, and then oftentimes emergent C-section to fix the problem. Placenta accreta is when the placenta implants itself too deeply into the wall of the uterus. And there's 3 types of accreta. There's actually placenta accreta, where the invasion of the trophoblast goes beyond the normal boundaries, so that's about 80%. Placenta increta, where the trophoblast extends into the myometrium, so it goes into the muscular wall, only in about 15% of cases. And then placenta percreta, where it extends through like the uterine musculature and can adhere to other pelvic organs, and that's rare. That's only in about 5% of all of the cases. But the problem with this is that the placenta does not separate readily, and so you end up with retained fragments. And so up to 90% of women who have some form of accreta will have at least a 3-liter blood loss, which is a significant hemorrhage. The end of this chapter kind of rounds out some other things that you have probably heard about, so I'm not going to spend as much time on them. Ectopic pregnancy is any time the pregnancy occurs outside of the uterus. The majority of those occur in the fallopian tube, and they account for roughly 10% of maternal mortality. The risk factors for ectopic pregnancy include prior tubal damage and pelvic inflammatory disease. Most patients will present with pelvic or abdominal pain, and roughly 60–80% of them will also have bleeding. If you have a patient who has severe unilateral abdominal pain, and they could be roughly somewhere around 6 weeks pregnant, it's important that you treat them as if they have an ectopic pregnancy. Abortion is the spontaneous or elective termination of pregnancy before 20 weeks gestation, and there can be induced abortion, which is medical or surgical, and then elective abortion, which is the termination before the age of viability, at the request of the woman, but not for reasons of impaired health of the mother or fetus. Therapeutic abortions then are when there's a problem with the mother or the fetus. A spontaneous abortion is when the body, does something to get rid of the pregnancy, and about 80% of these are going to occur within the first 12 weeks, and the other 20% occur between 12 and 20 weeks. Typically, we don't do anything unless they have recurrent spontaneous abortions, and then we start to do some testing. Molar pregnancies or gestational trophoblastic disease can be molar and non-molar tumors. The one we're most concerned about is called a hydatiform mole, and this is benign proliferating growth of the trophoblast. The chorionic villi develop into kind of this massive cyst that has all of these grape-like clusters and no viable fetus. On ultrasound, it looks like a giant whiteout. The patient will experience signs and symptoms of pregnancy with abdominal cramping and expulsion of those little vesicles or those little grapes. So they'll tell you that they're passing like small little pockets of tissue. And usually you can see a molar pregnancy much earlier than a regular pregnancy because it's dividing and growing so rapidly. This puts you at really high risk for cancer. So the immediate evacuation of the mole with D&C, so aspiration and suction, dilation, and curettage is important. And then follow-up of HCG levels for at least 6 months to make sure that they've returned to 0 and stay at 0. If the HCG levels fail to return to 0, then further workup is required. After the HCG levels stay at 0 for 6 months, then pregnancy can be considered again. So there's no pregnancy for at least 6 months until you've had a 0 on your HCG level. And the important thing here for us is to teach and support, but also to emphasize the importance of the follow-up with the regular HCG levels, because there is that risk that this is going to turn into a cancer, so a malignant trophoblastic disease or choriocarcinoma. And it's not that they're common, but just it's important that people continue to get their follow-up. Sexually transmitted infections can impact the fetus as well as the mother. So things that we worry about, like gonorrhea, chlamydia, can cause not only pelvic inflammatory disease, but they can also lead to blindness in the infant, as well as infertility in the mom, and then other cancers like cervical cancer and other cancers. In your book on page 166 through 168, they talk about sexually transmitted infections. Ophthalmia neonatorum is neonatal conjunctivitis in the first 28 days of life. And things we think about would be gonorrhea, chlamydia, staph, or strep pneumoniae. If it's not treated, it causes blindness. So that's why all babies get eye ointments or drops at birth with the erythromycin. Remember that for both gonorrhea and chlamydia, the mother oftentimes will have no symptoms at all. So it's important that those cultures be collected during the initial screening. And also remember that people change partners during pregnancy, so if there's a change of partner, rescreening is important. In your book on page 168, it says that breastfeeding is contraindicated for the mother who's HIV positive, and that's not true. In places where access to clean water and easy access to a good infant formula is not available, then they do recommend breastfeeding. So breastfeeding is contraindicated if the mother has adequate resources and ability to access clean water and fresh infant formula, because HIV can be transmitted through the breast. Torch infections, again, these are teratogens, toxoplasmosis, other like hepatitis B, rubella, cytomegalovirus, and herpes simplex. For toxoplasmosis, remember to avoid eating raw meat and contact with cat feces. For hepatitis B, the infant receives the vaccine at delivery, as well as most adults now are vaccinated. For rubella, the mom should not receive a vaccine until the postpartum period, so we don't vaccinate pregnant people, and that's pretty critical. Cytomegalovirus, there is no treatment. And for herpes simplex virus, there is no cure. If the woman has active lesions during delivery, the neonate will need to be born via C-section to avoid transmission. Trauma during pregnancy is the leading cause of maternal death, most likely from either abdominal or head injuries. And motor vehicle accidents and gunshot wounds, as well as domestic abuse, fall into the top categories. The two catastrophic events that occur during blunt trauma to the abdomen are placental abruption, which causes that hematoma and then destruction of the placenta, the decidua, and then uterine rupture, which causes internal hemorrhage and potential loss of life for both the maternal and fetus. Pregestational complications are women who enter pregnancy with a pre-existing disease or chronic medical condition are increased risk for complications and considered high risk. So cardiac disease during pregnancy is either congenital, acquired, or ischemic. If you think about, the fact that you may not have had a problem prior to, so that would be a congenital problem, but you develop a problem during pregnancy, then that's an acquired. Or if you have an MI, or a blood clot or something, then that would be ischemic. So think about the physiologic changes that occur during pregnancy in terms of cardiac. And that respiratory as well. So we can develop pulmonary hypertension, pulmonary edema, congestive heart failure, and maternal or fetal death from cardiovascular disorders. Looking for rapid weight gain and edema as evidence of left ventricular failure. So kind of heart failure signs and symptoms that you're looking for. dyspnea, orthopnea, paroxysmal nocturnal dyspnea, syncope, palpitations, chest pain, fatigue, cyanosis, and fluid retention all sound pretty much like the non-pregnant person who is in heart failure as well. Pulmonary disorders. So women with a history of compromised respiratory function can decompensate during pregnancy. Things like asthma and other respiratory illnesses. So looking at the overall rate and depth and work of breathing, and teaching the woman what medications are safe to use during pregnancy. The gallbladder and the presence of gallstones during pregnancy. Approximately 8% of pregnancies will end up with gallstones, though they didn't have them before. And so the person will have kind of colicky right upper quadrant pain, may or may not have a fever. And, usually we try to just manage it conservatively. So IV fluids, rest, gut rest, sometimes even NG tube and antibiotics. But if they need to remove it, it's ideally laparoscopic surgery to decrease the risk to the pregnant belly. Remember that the person is at incredibly increased risk for a DVT. So there's the hypercoagulable state, the increased fibrin generation, the increased coagulation factors, the decreased fibrinolytic activity, the venous stasis, increased blood volume, and compression of the inferior vena cava and pelvic veins during the end of pregnancy increase the risk of 5 times over a non-pregnant woman. If the person gets put on bed rest, if they're obese or have severe varicose veins, if they become dehydrated or injured, or have any other medical problems such as diabetes, heart disease, or renal disease, then they would be at even more increased risk for a DVT. Keep in mind that even though your book mentions Hohmann's sign, that it is now considered not to be an accurate assessment tool. So really you're looking at dependent edema, unilateral leg pain, erythema, low-grade fever, and if it travels to the lungs and becomes a PE, shortness of breath, tachypnea, tachycardia, dyspnea, pleuritic chest pain, fever, and anxiety. The most recent literature actually says that it's safe to CAT scan pregnant women if you suspect a PE because a D-dimer is always elevated during pregnancy. However, a lot of times we'll still do a VQ scan to assess for blood clots. And then if we're going to use heparin or Lovenox or something like that, you're going to need to teach the patient how to do it. Maternal obesity increases the risk for things like preeclampsia, gestational and type 2 diabetes, and DVTs. And so just extra careful education and monitoring of the obese pregnant patient is important. And substance abuse. So substance abuse includes smoking and tobacco use, and that increases the risk of premature delivery, low birth weight infants, and stillbirth. Women who stop smoking during the first trimester will have decreased risk factors to those of people who didn't smoke during pregnancy. So nicotine reduces uterine blood flow and causes transient intrauterine hypoxemia, which leads to essentially strangulation or constriction of the blood flow to the fetus. Alcohol use during pregnancy causes physical, mental birth defects, preterm births, and miscarriages. And if you've ever seen a child with fetal alcohol syndrome, it's a fairly significant disease that's there's no recovering from that. So it takes a lot of time and effort to care for an FAS baby. Illicit drugs. So according to this, 5.2% of pregnant women use illicit drugs such as marijuana, cocaine, amphetamines, heroin, and ecstasy. Women who use illicit drugs are counseled to stop, except for heroin users, for whom methadone treatment is recommended to prevent stillbirth. So the current literature supports not stopping heroin use during pregnancy because of the acute withdrawal and trauma to the fetus, which is the reason why we also don't give Narcan to pregnant people, because it can cause stillbirth. Acute use of cocaine during the third trimester can cause preterm labor, premature rupture of membranes, placental abruption, precipitous delivery, and increased risk of meconium in utero, which can lead to respiratory distress for the newborn infant, and then premature and low birth weight infants. Heroin use during pregnancy is linked to, unfortunately, lots of problems. Withdrawal, meconium aspiration, sepsis, intrauterine growth restriction, and neurodevelopmental and behavioral problems. Remember to use Subutex or methadone, not Suboxone, and not Narcan. Marijuana causes tachycardia and low blood pressure, which causes poor perfusion, and infants can be born addicted to marijuana. This causes altered response to visual stimulation, increased tremulousness, and high-pitched cry. And we do a sneeze count on marijuana-addicted babies to see how they're detoxing and coping. So with all of this, we have risk for preterm labor, preterm premature rupture of membranes, poor weight gain and nutritional status, and placental abnormalities. We also have risk for stillbirth, low birth weight, premature birth, miscarriage and spontaneous abortion, intrauterine growth restriction, neonatal withdrawal syndrome, and sudden infant death syndrome. Our goals have to be to screen and then refer to treatment programs and conduct frequent urine toxicology tests. Also keeping in mind that domestic violence increases with drug use, and provide a lot of education as well. Women, we find, are more receptive to treatment and lifestyle changes during pregnancy because they're seeing themselves as a parent or provider, and therefore this could be a good window of opportunity to provide those educational tools and support and have them actually have a successful transition.